welcome you all on behalf of myself, the moderator and the judges of the session. This is Cataract session 4 and we are about to start it. Apologies for the 4 minutes delay and apologies for the reshuffle of the order. We'll invite Dr. Prateek Nishant to start his paper, which is titled Opposite Clear Corneal Incisions versus Steep Axis Incision in Reduction of Total Corneal Astigmatism. Dr. Prateek, here you go. Your time starts now.
Thank you, esteemed chair. Ladies and gentlemen, good evening. This is my paper on comparison of efficacy of opposite clear corneal incisions and conventional clear corneal incision in reduction of total corneal astigmatism in patients undergoing phacoemulsification. I have no financial disclosures or conflicts of interest. Approximately 33% of patients undergoing cataract surgery are eligible for treatment of pre-existing astigmatism, and this is important to achieve spectacle independence. This is possible by manipulation of corneal incision parameters, not only the size, location, and shape, but also the number. There is an enhancement or flattening of effect of two opposite clear corneal incisions as compared to a single incision. Previous studies have documented this with the use of 2.8 to 3.2 millimeter keratomes. The efficacy of 2.2 millimeter OCCIs are yet to be quantified. The aim of the present study was to compare the efficacy of adding a clear corneal incision opposite to the main incision on the steep meridian versus performing surgery on the steep meridian alone in 2.2 millimeter phacoemulsification, introducing the pre-existing corneal astigmatism. This was a retrospective clinical study in 34 patients of senile cataract who underwent clear corneal phaco with monofocal non-toric posterior chamber intraocular lens. The eligibility criteria were as follows. All cases with disorders which could modify corneal astigmatism were excluded. After thorough preoperative examinations, the patients were subjected to telecentric keratometry of the IOL Master 700, and all surgeries were performed by a single experienced surgeon without limbal markings, using approximate limbal anatomical landmarks as assessed in the preoperative period on the slit lamp. The same type of monofocal aspheric foldable IOL was implanted in all the patients. Patients were divided into two groups. The group 1 comprised of 17 patients who underwent phacoemulsification with single clear corneal incision of 2.2 millimeters, and these patients had total corneal astigmatism of less than 1 diopters. In group 2, it comprised of patients, the same number of patients who underwent paired OCCI with the same 2.2 millimeter keratome after implantation of the IOL with the anterior chamber maintained by the OVD. These patients had total corneal astigmatism of more than 1 diopters. Post-op follow-up at 1 week, 1 month, and 3 months were done with a recording of the total keratometry by the same means. The results were statistically analyzed using the paired and unpaired t-test and chi-square test. Of the 34 eyes meeting the inclusion criteria, 17 were in group 1 and 17 in group 2, 11 men and 6 women in each group. The groups were comparable at baseline as regards to age, intraocular pressure, and axial length. There were no statistically significant differences. This is a table and chart showing that the baseline astigmatism in two groups was significantly different. However, both groups achieved significant correction of the total corneal astigmatism at the end of 1 month. The net change of astigmatism achieved at the end of 1 month for group 2 was approximately double as compared to that of group 1. The results at 3 months were comparable with the findings at 1 month. Approximately double correction of astigmatism was again achieved in group 2 as compared to group 1. These results were statistically significant. So astigmatism is the major cause of suboptimal vision after cataract surgery. Other existing modalities for treatment of corneal astigmatism concurrently or sequentially have their own disadvantages, including arcuate keratotomy, toric IOL, and excimer lasers. Steep meridian CCI as for phaco is recommended to reduce astigmatism, but single incision is insufficient if the astigmatism is beyond 1.2 diopters. OCCIs are self-sealing, pose no additional risk, and require no extra instruments and are effective. How effective? Previous studies have shown that variable correction of astigmatism is possible with 2.8 millimeter and 3.2 millimeter OCCI. This effect is not yet documented for 2.2 millimeter incisions in literature, which are more common nowadays. So varying incision lengths and amount of and type of pre-existing astigmatism preclude accurate comparisons with these studies. Moving on. In our study, a 2.2 millimeter keratome was used, which explains the smaller change observed compared to previous studies. And we observed that even a 2.2 millimeter OCCI has encouraging results by correcting mean astigmatism by about 0.57 diopters, even in the short term. That is approximately 1 month follow-up, and about similar 0.62 diopters in 3 months. The study is not without limitations of retrospective design, small sample size, and loss to follow-up. Long-term outcomes as larger sample are necessary to establish the quantum of effect that 2.2 millimeter OCCs may have in correcting corneal astigmatism. To conclude, OCCs are reliable, easy, and cost-effective for management of mild to moderate pre-existing astigmatism with enhanced effect over single clear corneal incisions. These are my references. Thank you.
Thank you, Dr. Prateek. Before we move on, I'll just request the hall manager to ensure that the clock is ticking. It's sort of stagnant, and we couldn't keep count on the time that each presenter is. The clock should tick. Okay, start a countdown the moment the presenter starts presenting. Thank you. So the sessions, the segment's open to judges. Questioning.
Okay. So you said this is in a first study you say which is for a 2.2, but there are already other studies which have compared with a 2.25 incision at a single incision on an steep meridian.
Exactly,
so
sir.
what was that? You put both the incisions on an steep meridian, or one temporal and another on a steep meridian?
Both incisions on the steep meridian on diametrically opposite. So this effect has previously been quantified using 2.8 or 3.2 millimeter astigmatism, but those were comparatively older studies when that size of a phacoemulsification was more popular. Now with the advent of 2.2 millimeter incisions, we now no longer use those keratomes. So,
but if you calculate the centroid value, 2.2 millimeter incision doesn't cause too much of an astigmatism.
Exactly.
Whether it's in that incision or as an OCI, both together.
Yes, I agree with that, sir. But actually, this study was done when to estimate whether you actually need a larger incision to correct that amount of astigmatism, or the quantum of effect is sufficient to say if a patient comes with a 1.4 diopter astigmatism, you correct it by 0.6 and he lands up with 0.8. So do you need a larger incision to correct the astigmatism below 1 diopter?
No, even if you consider the fact that the centroid does predict that a 0.2 is what is resultant of a 2.2 millimeter incision, since you did it on both sides, a 0.2 and a 0.2 make it 0.4, you said, I think the resultant was 0.57, which is still acceptable. But there are two things that are lurking in my mind. I can't help myself but ask you. First is you did see it 1 month post-op, and there's going to be a drift after that too. So yes, this 0.57 might not stay as 0.57. It might lessen, it might worsen too with time. The other thing is you said that you have not marked the cornea preoperatively. Exactly. So how did you know that you are incising along the steep axis?
Okay. So the steep axis was reported by the IOL master report, and the operating surgeon, while examining on the slit lamp, approximated the limbal marking using the slit lamp slit angulation, and he identified a particular limbal landmark at that point. So what this leads us to believe is that marking is not all that necessary. You can even estimate your steep axis incise.
No. See, there are a lot of, I believe they're all done under topical, and we know that there's a lot of cyclotorsion that happens yes, once the patient is lying down on the table. So perhaps you can take it a step further, this study, and this continues as a prospective one instead of a retrospective one. And then maybe you can, because why I say this is because astigmatism is not a number, it's a vector.
Exactly.
So if you falter in wherein you have placed your incision, if it moves around 10 degrees, and the whole vector factor changes.
Right.
So you cannot conclude that it flattens the axis and causes an astigmatic flattening up to this extent with a 2.2.
Right.
But
exactly.
Yeah, I mean, this is a good beginning, though I laud you for that. But maybe you can just take it further by marking it and ensuring that you are right bang on target when you are
exactly. And this prospective study is in fact in process with the markerless toric system Callisto. So here what has been done is to estimate a limbal landmark, and that is the classical way of doing this when we don't have a toric marker or a bubble marker or whatever it is. Now with cyclotorsion, that limbal landmark is quite less likely to shift because of the adherence at the limbus.
So it's always not possible.
I can understand, sir. I can understand, but this is particular to this particular study.
All right.
I accept that is not the standard practice.
Thank you. Thank you, Dr. Pratik. You stood up really well to the questions. Anything from you, sir? We move on then. Thank you so much. You can climb down. So next we go to Dr. Sanjeev Jadia. And his talk is titled on the story of how I performed cataract. Now this is interesting. The story of how I performed market cataract in a lion's eye. First ever phaco on Asiatic land. I'm sure it is. Please carry on, sir. Your time still not running. Starts now.
Thank you, judges and panelists, for giving me an opportunity. This is the story how I operate the lion's eye. This is the wild animal. This is in Sasan, in Junagadh, in Gujarat. It is the last and first home Asiatic lion. I'm going fast slide. How the problem discovers. The trackers of the forest department, this is not a human, it is a wild animal. The problem starts, trackers know the lion was following abnormal behaviors in one of the range of forest. Only responding to light, frequently head injury, sitting at one place. There are so many things. He is not hunting even. So he called me to examine the patient. They caught at the rescue center and we go there 100 kilometers from the Junagadh, far distance. We there examine that lion on torchlight. On torchlight we saw that bilateral mature cataract was done. In a rescue center, in a large case also, he is not even taking his meal. He was by smelling, he go to the meal. Only smell he goes, and head injury is also due to that. Okay, he followed the urine of the pet animals and he broke the pet animals cages and hunting only pet animals, not wild animals. This is how we examine in the smaller cage that. Now the challenge is what to do now. After the permission of the forest department, I told him, transfer him to nearest zoo where hospitals are available in Junagadh city. We examine at night time. We started our examination. After 1 month, everything was in mind. What to do now? After 1 month of first detection, we started examining at night. From gun tranquilizer, we tranquilized that patient. A-scan did, pachymeter, keratometry, all did. Although we are in dilemma, meantime, these are the photographs that we did that time. Meanwhile, one accident in train accident, where lion came into postmortem. I dissected that. This is the lens last dissected position. I saw a keratometry in dissected eye also. These are the preoperative A scans. AC depth was 10. Lens thickness is almost 8 millimeter. The keratometry of our machine is not 35. Less than 35 is not possible. So we concluded this way, and other on the photographs of the other, so we conclude around 30-31 keratometry was there. Lens thickness is 5 to 6 millimeter. ACD is 10 millimeter. Pachy is 1000 micron. It is 1 millimeter thick cornea. White to white is 24 millimeters. It is large, and a pupil size is also more than 6 millimeter. Usually these are nocturnal animals. They move at night. Asiatic lions are. So night pupil was mostly more than 6 millimeters, 6 to 8 millimeters. We now challenges are how to use calculate the IOL power. We contacted then Warren Hills, Professor of Ophthalmology, Visual Science, Arizona, USA. He guided us Redzolf formula and ELP, expected lens position. And we all, after all diameters, we calculate this. This is the response from Dr. Warren Hill. These are the formulas, all are in meter. Formulas are in meters, and our is in micron and millimeter. So we calculated this. Our machines also calculated like this 19, or lastly all we concluded 21 or 21.5 will put that IOL. Overall size is 24 millimeters. Optic diameters is 8 to 10 millimeters. Now we are searching who is manufacturing. We tried so many manufacturers, Biotech, Envision Germany we contacted. That time Corona was there. So he did not respond. He told that okay, we'll make this, but not possible this time. He gave us the trying to give us the lenses of horse, but it is not fitted and not possible. The size is not matching this way. Orolab Care Group. Finally, Orolab made this veterinary IOL this size, 24 millimeter, 9 millimeter optics, hydrophobic IOLs they made. Now the challenge is IOL is there, or everything is there. How to operate? This is the animal. He is not lying like us, but he is lying sideways, not exactly. So we did microscope, Carl Zeiss microscope, and make a stand in zoo separately, and start all devices are made for that only. It is not possible. This is the stand. This short video is there. How we make this stand. This is the OT table. Few days ago we started how we operate, how we plan our cataract surgery for this patient. He's 5 years old, 160 kg. His life is around 18 to 20. He's 5 years old. That's why bilateral cataract is there. Totally blind, wild animal. The forest department has tried. They will do operate. This way we operated. IV line was taken. Tranquilizers was given. These are the preparation, pre-operative, all OT and all this. We did phaco abbot, ellipse. This is the speculum, but not possible. There is nictitating membrane that is disturbing us, and the eyeball going down and down. Without speculum, I started the surgery. Few of our instrument, few of and other instrument we taken. Some of the videos are from outside, some of the from the microscopes. These are the spy side ports. After tranquilizer, the eyeball is very soft. Refined blue dye injected, mature cataract, I did CCC. Capsule also very thick. Pigmentation. Okay, I'll just finish. This is the CCC. I complete. Now the IOL I put in the bag. The overall time is more than 1 hour, 1:30. We planned bilateral at the time, but it took 1.5 hours for first. So we planned 10 days later, and we did bilateral surgeries. Thank you.
Anything, Subhashish sir? I think you have a microphone there, just behind.
Hey, chalu kari thoda first.
This is a really great job that you have done, and I personally feel privileged to see this in your video. I don't know whether we'll ever see in lifetime. I don't know.
Thank you.
You have operated hundreds.
Unless you consider me a lion and coming to get operated by you.
Yeah. So well, I don't know anything else. We have got no experience.
I am very much
we
blessed
must
to have
congratulate
a serve Asiatic line.
Yeah.
Thank you.
I
This
would
is
just
the
like
in
to.
the bag IOL, first POD, third POD. Within 3 days, it is very much clear.
No anterior chamber
One,
reaction. nothing.
no, nothing. One suture, 10 o'clock, 10 or 0, I took one. Holder and folder are also, Epsilon gave us special for design for this. Like, everything is specially.
Yeah, I
for
was just
designed
about
and-
to ask you that because the optic size is so,
So large.
large. So
Ah.
how did you fold it in?
For,
So folder. and the-
especially from Epsilon, they give us.
But I'm just interested to know what preoperative aseptic protocol did you take, because I saw that the eye was pretty exposed, and I think I saw your bare hand, so you're not even gowned, if I'm not wrong.
No, that is the only examination.
Okay.
Then we start.
After that, you
that
scrubbed
is
and-
okay. What
Alright.
to prepare? Then we start.
Okay.
but we don't know what is the possibilities are there.
Okay.
Then we'll start.
Mhm.
Whatever, OT, Basilol, and everything, and pre-operative, all betadine was and everything was done with gloves. We did surgery, but speculum not possible. One veterinary doctors he hold his lead and I'll operating that. But very shallow AC and 10 millimeter is ACD. There are so many times air bubbling are there. 25 cc OVD was took for one surgery.
Yeah, I think not even the phaco needle would
It
adjust to
doesn't-
the AC depth
largest,
plus
longest.
absolutely.
I
So
took.
10 plus 8 is almost 18 millimeters.
18
So you have to go right to the
Right,
neck of the handpiece just to ensure that the tip is reaching somewhere close to the posterior plate.
Even
Amazing.
Now whole video
Even
is
then,
there.
even then, the obliquity would be so much that it would
bold.
create a lot of corneal folds and
Very
maybe
much
mar the
folds.
visibility
very
also.
soft eye, very fold.
Great, good, thank you.
Thank you, sir.
Move on to the next one. This is from Dr. Amrita Vidushi Bajaj, and her talk would be on biometry in post-RK with adjunct LASIK.
Shall I start? Good evening, everyone. My topic for today is biometry in post-radial keratotomy with adjunctive laser-assisted in situ keratomelusis eyes. So I know what everybody would be thinking, that this is a biometry session, so it's going to be all boring with the newer IOL bar calculation formulas or the newer IOL machines that we are getting to get more precise calculations. But I think, hold on, we have much in store for you all. So with all the present instruments and the newer IOL power calculation formulas, we've been getting better and better for the virgin eyes for the routine cataract surgeries. Next in line, we went ahead with the patients with previous refractive surgery. But now today we have with us a patient with consecutive different refractive surgeries. So post-refractive surgery eyes, we have much challenges in post-RK eyes because it changes both the front and the back corneal curvature. The standard keratometry overestimates the corneal power. There's a low ELP estimation and thereby underestimation of the IOL power. Following this, in post-LASIK eyes, we have another set of challenges where the anterior corneal curvature changes and the changes in the pachymetry, thereby wrong ELP prediction. Now, there are various formulae which have been used in post-refractive surgery eyes. Some of them use the anterior corneal measurements only, and some of them use both the anterior and the posterior corneal measurements. And now we have web-based calculators like ASCRS calculators also, which gives us a wide range whether we are going to operate a patient with a prior myopic LASIK or a prior hyperopic LASIK or a prior RK. But again, we have no set of formulas which helps us define what to do in patients with post-radial keratotomy along with LASIK. So our patient presented to us as a 43-year-old male who had underwent a radial keratotomy followed by a laser vision correction elsewhere, and came to us for cataract surgery in 2019. Presently, as you can see, that this patient was actually following up with us since 2013 for his retinal follow-ups. In 2019, he complained of diminution of vision in both eye, right more than left, and his present glasses prescription was also available with us. Following this, as a part of routine surgery, we went ahead with the Lenstar biometry and noted that we were not able to record any of the keratometric readings, particularly the flat and the steep meridians, so we didn't know which keratometry readings to be used for this patient. Following this, we went ahead with our next set of investigations with the pentacam, and we found out that the K1, K2 readings for the right and the left eye were recorded on pentacam. And as a routine, we look at a post-refractive surgery, the holiday EKR detailed report, which gives us a fair idea about the EKR flat and K1 and K2s with a EKR 65 mean. So we went ahead with the 29.34 in right eye and around 27.62 in the left. Now, again, the question still remains the same, that which IOL-PAR calculation from the web-based, the ASCRS, which is the maximally used these days, should be used, whether it should be the prior myopic LASIK or the prior RK formulas. We thought we'll use both of them, but our challenge was not just limited to this point. The prior RK formulas gave us a wide range between 17.32 till 21.9 diopters of lens powers. And in the prior myopic LASIK, when we started putting the data, we could only and only get ahead with the OCT-based formula, and no other formula was being calculated by the web-based calculator. A similar thing went ahead with the left eye also, and the range was from 17.5 till 24 in the right, and from the OCT-based formula, we got 23. Now, we went ahead with the manual keratometric readings from the LensStar also, the minimal reading being 30.68. So we entered both the keratometries, and the IOL-PAR calculation came out to be 18.5 and 19. For further evaluation, we went ahead with the eye trace also to look at the aberrations, and obviously the aberrations are very high that the eye trace was not able to differentiate between the internal and the corneal, but it did give us the potential visual complaints post-surgery which we can encounter. So this is the summarization of all the things, that the patient has a BCVA of right more than left with normal NCTs and a wide range of keratometric readings from all the machines that we have gotten ahead with. So the issue remains the same, that in both RK and LASIK, there's no holistic method that we can go ahead with. The central pachymetry seems good, which gives us a good idea that the LASIK ablation was probably minor for the myopic residual RK refraction, and there's a definite central flattening. So now we have a patient with no previous records available, and the LASIK ablation being minor, we are not going to use a Haig's L. We have a double K with no history method to be used here. So we took the average central corneal K, and we presumed the historical K as 43.5. The axial length was recorded and the AC depth. And now the point is that we have to adjust the axial length with the Van Cox method with different formulas that are there. And with the right eye, we went ahead with 24 diopters of IOL-PAR implantation. Once we implanted this IOL, we saw that in the right eye, we were getting some minus 0.5 of spherical error as well. So when we were planning for the left eye, we went ahead with 25, erring on a little of a lesser correction so that we don't again go for a myopic correction. So post-operatively, we were very satisfied with the left eye results, and we only got a cylindrical PAR correction with the BCVA of 6/9. To conclude, now there's no specific one IOL-PAR calculation formula. You know why this is important? Because these days we are getting all these patients with post-refractive surgeries being operated elsewhere, and maybe there are multiple surgeries being done in different patients. So we are supposed to come up with a conclusion for this, that what exactly are we supposed to plan for such patients. So we have to go back to the basics, find out the IOL-PAR measurements, go with multiple IOL-PAR calculation formula, and we have to look into the consistency with each formula. And obviously these patients are post-refractive surgery, so expectation level is very high. They have to be realistic expectations. There are two case reports that have been published in the American Journal of Ophthalmology, in which the first report says the B/F ratio should be considered, and the second one says that particular Haig's L formula, Sharma's and Barrett's 2K should be considered, but in our experience, we could not go ahead with. So what our experience adds is that in patients presenting with adjunctive refractive surgeries for cataract, no one formula can be used, and axial length adjustment is a must, along with comparison of IOL-PAR and various formulas. Thank you.
Sir.
This is just a one single patient we are talking about.
Yes, sir.
Had there been more patients?
So basically in our setup, what we have seen, the patient usually comes up with one single type of refractive surgery. So this was a rare case in which we were stuck because we only had one patient. I think we have one more lined up, but we haven't started working up that patient yet. So we are not sure about how we are going to work that patient up.
Going to work out also.
Yes, so that patient, if that one comes along, then we can obviously add. But then otherwise also there were only 2 case reports that we came across, and none of them was very consistent. So we just wanted to add this to the literature to make sure that everybody can have, because these days refractive surgery patients are coming on and off of cataract surgeries presentation, operated elsewhere. So everybody is having challenges regarding the same.
I think it's a excellent study that you have carried out and worked it, in depth.
Thank you.
And I think we should wait for more studies to be presented so that we can come to some conclusion.
Yes, ma'am.
Good presentation.
Thank you so much.
Go the next one.
Next one.
Yes.
Who's the next one?
Dr. Jyoti Goyal.
Sir, microphone on.
Yeah.
on.
Mic is.
And light is on. Yeah.
Okay, thank you. Yeah, we invite Dr. Jyoti Goyal. She will be presenting her paper on a sling to prevent intraocular lens swing, a prospective interventional study interim analysis. Dr. Jyoti Goyal.
Okay, a very good afternoon, everyone. So before I begin with my presentation, I want to address all the residents and postgraduates who are sitting over here who, just like me, have just begun their journey towards the cataract surgery. Guys, this presentation is dedicated to you all. So these are the abbreviations that I've used in my presentation. So let me introduce you all to my topic briefly. Every year, around 20 million cataract surgeries are performed, out of which around 2,000 to 3,000 surgeries are complicated by either posterior capsular rent or zonular dialysis. And around 115 patients with potential vision are left with suboptimal vision because of no IOL. So why am I talking all these big numbers is because in my study, I have addressed these complications and worked upon a solution, a technique which is simple, stable, for well-centered placement of IOL, and it also prevents one of the most dreaded complication of any cataract surgeon, that is the IOL drop. So this is a video where I will be showing how this technique is used. So this is a case which is complicated by intraoperatively posterior capsular rent, and now we are going to place the IOL in the sulcus using this suture sling technique. So step 1 is to pass the 10-0 nylon suture through the dialing hole of the optic. After that, we will be directing the leading haptic into the sulcus as shown in the video. This is followed by dialing of the trailing haptic with the Sinski hook dialer, and we have to make sure that we dial it horizontally into the sulcus. After that, we perform a thorough anterior vitrectomy, and we have to make sure that the entire vitreous is cleared from the AC. We washed all the viscoelastics from the AC, and after ensuring the stability of the IOL, we cut one end of the suture and pull the other end of the suture gently. So we are planning to use this technique in 58 eyes in our hospital, which is a tertiary eye care institute, and this is an interim analysis of this prospective interventional study. So in my study, I have included the patient which have intraoperatively PC rent or where there is a zonular dialysis of less than 2 quadrants. And patients where there is a large PC rent or inadequate ciliary sulcus support, or cases where there is a zonular dialysis of more than 2 quadrants, or patients where lens material has already dropped into the posterior segment are excluded from this study. So post-operatively, these patients are being followed up at day 1 week, 6 weeks, and 3 months for visual acuity assessment and detailed anterior and posterior segment assessment. And in addition, at 6-week follow-up, we are looking for IOL centration in slit lamp photography and IOL tilt via ultrasound biomicroscopy. So on slit lamp photography, we calculate the ratio of limbus to the IOL optic edge, and if this ratio is between 0.5 to 1.5, it is said to be centered. On ultrasound biomicroscopy, we are calculating the tilt of the IOL. So we draw a line passing through the iris plane and another line that is passing through the optic of the IOL, and the angle between them is said to be, if it's more than 15 degrees, the tilt is said to be significant. So this is our data collection sheet, and till now we have enrolled 48 patients in our study, and this is interim analysis of 10 patients. So on the analysis of 10 patients, these are my results. All the IOLs were stable and centered without any significant tilt. There was no intraoperative or post-operative IOL drop in these 10 patients. The logMAR visual acuity improved significantly at 1st and 6-week follow-up. So finally, I would like to conclude with this following conclusions, that this technique is very useful in trainee or novice surgeons, especially when they have many maneuvers to do because of their there is a more chance of haptic slippage in these novice surgeons. This sling, it acts as a rescue anchor, and it is a very simple and effective technique which increase the window of safety for all the novice surgeons. And there is a minimal, it requires very minimal surgical time and expertise, and this is very useful especially in resource limited settings, places where there is no vitreoretinal backup. This technique can be a saving technique. Thank you.
Thank you, Doctor. But were the lenses PMMA?
Yes.
Yeah.
Non-foldable PMMA
Non-foldable
lenses.
PMMA lenses.
Yes.
So you're not putting any stitch and something, just you're
No,
pulling
no.
it out after you've
Yes.
placed it in the sulcus.
Yes, yes,
So
yes.
this is just another safety measure
Right.
for the novice, as you said. We
Right,
understand.
Just for our information, how many patients have you had to resort to this technique?
We have used this technique in 48 patients till now. We are planning to use it in 58 patients. In 48 patients, we have not experienced any major complication related to the sling. There was this one case where there was entanglement of the sling, but then it was that patient was left aphakic because we also use the sling to, we have this guide to explant the IOL using, because there is this anchor in our hand where we can direct the IOL, we can center it basically, because we have the sling in our hand. There is this anchor we have, so that has helped a lot, especially for the trainee surgeons who have just begun. 10-0 nylon suture. Thank you so much, sir.
Our next presentation is Dr. Riya Batra is absent, I presume. So it will be Dr. Siddharth Sheth, defocus curve and image quality metrics in eyes implanted with trifocal and EDOF intraocular lenses. Dr. Siddharth.
Good evening, everyone. At the outset, I would like to thank AIOS for giving me this opportunity to present at the podium. My topic for presentation is defocus curve and image quality metrics in eyes implanted with trifocal and EDOF intraocular lenses. I have no financial disclosures. With advent of newer IOLs and every day we have some new IOL in the IOL world. So patients' expectations for unaided visual outcome after cataract surgery have been increased tremendously in past 1 decade. Presbyopia correcting IOLs have trifocal and EDOF lenses. Trifocal lenses clears vision at specific focal length, whereas EDOF, that is extended depth of focus IOL, provides continuous range of uncorrected vision over intermediate to far distances. There are a few parameters which we use to or which we can use to analyze the post-operative results. One of them is the defocus curves, which allows surgeons to understand the impact of post-operative refractive errors, which sometimes happen even despite of perfect biometry, on the visual performance of various presbyopia correcting IOLs. Higher order aberrations and modulation transfer functions are image quality metrics, which helps in understanding optical quality of various intraocular lenses. So these are the two intraocular lenses which we analyzed in this particular study, of which the first is the Panoptix, which is a trifocal IOL, which is a diffractive aspheric trifocal IOL, and the second one is the VVT IOL, which is a non-diffractive EDOF IOL. So the purpose of the study was to evaluate the defocus curve and image quality metrics in eyes implanted with trifocal and extended depth of focus IOLs. It was a prospective study. Subjects implanted with these IOLs were analyzed. Sample size was 87 eyes with Panoptix lens and 18 eyes with VVT IOL. So inclusion criteria were patients aged between 40 to 75 years and post-operative best corrected visual acuity of 0.2 logmar unit or better. Exclusion criteria: subjects with any other ocular pathologies, systemic diseases, pre-operative corneal astigmatism of more than 1.5 diopters, irregular astigmatism, previous history of any refractive surgery, any complicated intraocular complication or hypermature cataracts, or So how we analyzed the defocus curve was at 1 month post-op follow-up, monocular distance corrected defocus curve was measured in each subject using logMAR chart. So here whatever refractive error patient had, we put that error and then we analyzed the defocus. So the visual acuity which each defocus lens ranging from +2 to -3 diopter in 0.5 steps was measured in randomized order, and 2 sample t-test was done to compare visual acuity in eyes implanted with these 2 IOLs. Modulation transfer function and higher order aberration were evaluated using Hoya eye trace aberrometer. Internal higher order aberrations for 3rd, 4th and 5th order, and modulation transfer function was evaluated at 5, 10, 15, 20, 25 and 30 cycles per degree. Now again 2 sample test was carried out to compare the results. So results were the mean age for trifocal IOL was 58 years, and for ADOF IOL was 55 years. Visual acuity defocus curve showed visual acuity with VVT IOL was better at all the defocus levels except at 0.5 and -1 diopter. However, this difference was not significant clinically. For internal higher order aberrations, the internal higher order aberrations were similar in both the groups, whereas modulation transfer function, which is actually a function of image contrast to object contrast, was found to be significantly higher with Panoptix IOL at specific spatial frequencies of 15, 20 and 25 CPD. So defocus curve is basically for presbyopia correcting IOL, which helps in understanding IOL's performance at range of distances. Defocus curve were found to be statistically similar with both these IOLs. However, ADOF IOL had little edge over trifocal IOLs. This information could be helpful in better patient selection based on patient's need. We noted similar internal higher order aberrations in eyes implanted with trifocal and ADOF IOL. However, Panoptix IOL resulted in significantly better or higher modulation transfer function at higher spatial frequencies. So Panoptix is a spheric trifocal IOL which uses Enlighten technology, and it's designed for more comfortable intermediate to near distance, whereas VVT can, which is a ADOF IOL which is based on spherical aberration, it provides a better extended range of vision with slightly lower modulation transfer function. Thank you.
You are in your study, but you compared. You said you compared with an eye trace the internal aberrations.
Yes, yes, sir.
Right. And what was an astigmatism that you had calculated? What was a maximum astigmatism which was in your?
So we excluded astigmatism more than 1.5 diopter, sir. So any patients preoperative astigmatism more than 1.5 diopter we excluded. Below 1.5 diopter we used toric lenses in those cases.
What was your limit of toric lenses? Minimum astigmatism which you started with a toric.
0.8.
0.8. Okay. So you want to ask better, I just calculate.
So basically, what is the take-home message from this study?
Even though clinically or statistically the difference was not significant, but what we recommend is in patients where VVT IOL was put, they had a better defocus curve. Means if they develop some residual refractive error, they were able to see better. The visual acuity for that was better as compared to similar residual refractive error for trifocal lens. That was the first conclusion. And trifocal lenses offered a better contrast by means of modulation transfer function. So as compared to the ADOF lenses.
So you mean to say ADOF will be more forgiving lens?
Sir, for if there is a residual refractive error, probably it will be, but in terms of contrast, it will this trifocal would be
because
better.
Now the focus is on intermediate distances with
yes,
all
exactly.
this screen time, driving, and all things like that.
Exactly.
So I think definitely that is a better choice.
So even though we plan for plano post-operative, but sometimes if we get a surprise, probably ADOF will be more forgiving as compared to trifocal.
So that means your conclusion was, you said EDOF lens has a lesser contrast than in a trifocals.
Yes, sir. At the spatial frequencies which I mentioned, so that's what we found in our study. The trifocal lens had a better modulation transfer function or higher modulation transfer function as compared to the EDOF lens.
No, MTF. You said for the contrast. You said the contrast is better in trifocals as compared.
Probably, yeah. So, I was trying to say modulation transfer. Yeah. So sorry.
Okay.
Thank you.
Okay, the next presenting author would be Dr. Stuti Chand, study of conjunctival flora in patients undergoing cataract surgery in a tertiary care hospital.
Good evening, everyone. I'm here to present the study of conjunctival flora in patients undergoing cataract surgery in a tertiary care hospital. Postoperative endophthalmitis is one of the most devastating complications of intraocular surgery with grave visual consequences or even loss of an eye, with incidence being maximum following a cataract surgery of about 0.82%, followed by secondary IOL implantation, glaucoma surgery, pars plana vitrectomy, and intravitreal injection in descending order. The aim of the study was to isolate and characterize bacterial and fungal flora from conjunctival sac of cataract patients presenting to a tertiary care hospital, and also to analyze the effect of seasons and age on the growth pattern of the flora inhabiting the sac. Our study was cross-sectional observational study in patients visiting IOPD, and 320 eyes were included in the study over a period of 12 months from December 2016 to November 2017. Study period was divided into 4 seasons: Season 1, Season 2, Season 3, and Season 4. Season 1 was winter with temperature of 10 to 15 degrees Celsius. Season 2 was summer with temperature 32 to 40 degrees Celsius. Season 3 was monsoon with temperature between 20 to 30 degrees Celsius. And Season 4, autumn, with temperature 25 to 35 degrees Celsius. Three conjunctival swabs were obtained from patients diagnosed with cataract in either or both eyes and sent for culture via chocolate and blood media, Robertson cooked meat media, thioglycolate media, subrod dextrose media, following KOH mount. The study eyes were divided into 3 groups as Group 1, which comprised of eyes of patients aged 18 to 50 years. Group 2 comprised of eyes of patients aged 51 to 65 years. And Group 3 comprised of eyes of patients aged above 65 years. All the patients attending to IOPD of more than 18 years were included, whereas patients with infectious conjunctivitis, corneal ulcer, contact lens wear, patients on topical anti-glaucoma drugs, topical or systemic antibiotics were excluded. The outcome was measured on the basis of aerobic and anaerobic bacterial flora as well as fungal flora growths, which were identified on culture media. The correlation of seasons and age with growth pattern of the flora was also done. The conjunctival swab from 242 eyes showed growth out of 320 eyes, and out of the swabs which showed growth, 67.50 was gram positive, 7.18 was gram negative, and 0.93 was fungal positive. The organisms that were isolated in culture was maximum with Staph epidermidis, which was about 35.01%, followed by Staph aureus propionibacterium species. Correlating age with growth, the growth of organisms was seen maximum in age group. In Group 2, with consist of age between 51 to 65 years, and among this, Staph epidermidis was seen to be the highest in number. Correlating growth with seasons, the growth of organisms was seen throughout the year, and the findings in all 4 seasons was not statistically significant, whereas the variation of prevalence according to the season was seen maximum with was seen maximum in Season 1, that was between 10 to 15 degrees Celsius temperature, with gram positive being the highest in number. Discussing briefly about normal conjunctival flora, eyelids and conjunctiva harbor a significant number of bacteria and occasionally fungi, and these are the normal flora that secrete antibiotics. These act as chemical mediators. These maintain surface homeostasis and immunoregulation. These are not infectious under normal circumstances due to secretion of bacteriostatic substances, and they reside in decreased temperature due to evaporation of tears, exposure, and less blood supply. The range of conjunctival flora varies with genetic makeup, nutrition, age, sex, race, immunosuppression, ocular inflammation, dry eye, contact lens wear, antibiotic use, and surgery, external exposure, climate, and geography. The microbial flora of normal eye is the most common predominant is gram-positive cocci, and Staphylococcus epidermidis tops the list with 30 to 90%. Followed by Staphylococcus aureus, Micrococcus, and other common cells of conjunctival flora are gram-negative cocci, which Moraxella cataralis, Corynebacterium species, Haemophilus influenza, Klebsiella species, E. coli, Pseudomonas aeruginosa, Moraxella species, and among anaerobic organism, Propionibacterium species is the common. With increasing age, gram-negative organisms also become part of the flora. The most common organisms responsible for post-operative cataract surgery endophthalmitis is also Coagulase-negative Staphylococci, with Staph epidermidis being 70%, followed by Staphylococcus aureus, Streptococcus species, Enterococcus, and gram-negative bacteria, Propionibacterium acne, and lastly fungal. Endophthalmitis after cataract surgery is a severe complication, and Staph epidermidis have a better prognosis than Staph aureus. The important risk factors that are responsible for post-operative endophthalmitis are old age, diabetes, intraoperative risk factors such as post-capsular rupture, combined surgery, prolonged surgery, post-operative wound leak, vitreous incarcerated in wound, other than preocular tear films which act as host to several organisms, respiratory flora of surgeons and assistant, ambient air, and surgical instruments and devices including IOL irrigating solutions act as source of infection, and evidence-based prophylactic measures including preoperative installation of povidone iodine drops can help us to prevent post-operative endophthalmitis. To summarize, the pathogens causing endophthalmitis are mainly indigenous bacteria from sites on the ocular surface such as conjunctival eyelids and meibomian glands.
Please sum up.
To conclude, conjunctival swabs as routine preoperative investigation can identify flora likely to cause post-operative endophthalmitis, and thereby they help in implementing preventing measures accordingly. And the role of preoperative conjunctival swab is mainly important in high-risk patients in diabetes, immunocompromised, contact lens wearers, and one-eyed patients. This may be included as a part of routine preoperative workup of patients if resources permit.
Thank you, Dr. Stuti. So what is the aim of this study? You said you wanted to study, you have studied, you have found some important things. Maybe all of it is not new, but still you did a good job. So what was the aim and what do you recommend? Because this is the most important thing that we ophthalmologists do day in and day out.
So, the patient many times the patient with post-operative endophthalmitis, the organisms causing post-operative endophthalmitis could not be known. So taking conjunctival swab preoperatively and isolating organisms can help us to find out the organism responsible for post-operative causing post-operative endophthalmitis.
So, sir, madam, are you recommending that you do conjunctival swab test for every pre-op patient?
If resources permit, we are emphasizing to do the conjunctival
I don't know how
swab.
many people are doing it.
It's a very contradictory statement.
No, but the thing is,
We used to do it.
you have gotten a swab.
All of us have left it.
Yeah, left it because preoperatively we are
How
giving
many of you in your
antibiotics,
institute follow this? You see so many young
Preoperative.
people, most likely working in
turns out-
different places. You use conjunctival swab only in one eye. Any other?
both.
Sir, we have got our very esteemed chief of the RP center. Sir, what do you recommend? She's telling that it's
practice has been left for almost 2 decades now.
20 years.
Yeah.
That was when we started.
Consultatory evidence that conjunctival flora is cause for endophthalmitis.
They reside there. Yes, sir.
What we culture may not be same unless we do a genetics of those bacteria. I can't say this is the bacteria which is causing infection. So that is the point. You might culture staph and staph. But that step may not be the same step. That is the important part.
No, but the thing is, you said when you got on a culture positive, then what was something? How many days I mean, what was a precautionary measure? What antibiotic you used it? Whether the sensitivity, and then after that, how many days after that you repeated the swab and then did a surgery?
So we did not
Because
repeat.
that was not mentioned into that. Because
Yes, sir,
once you have a culture positive, whatever, I mean, even if it's an epidermis, but still you can't operate because you have a report positive with you.
So actually it is a cross-sectional observational study, so we did not follow the patient after cataract surgery.
Okay, it's a good beginning to study. You learn methods, but I think you have to do it further, take it further. Thank you. Next speaker, sir.
Yeah, last speaker of the day for this session. It's
No one else?
yeah, Dr. Kripali said she is the presenting author. Optimizing IOL power in patients undergoing cataract surgery in eye myopia.
बाकी तो नहीं है ना last. It is there. Absent.
She's absent. Good evening, everyone. My topic for today is optimizing IOL power calculations in patients undergoing cataract surgery in high myopia. So our aim is to optimize the refractive outcomes in high myopes undergoing cataract surgery with implantation of monofocal IOLs. The objective is to evaluate monovision outcomes and glass independence in these high myopes and to ensure the target refraction is achieved. So as we all know, the high myopia is defined as myopia more than or equal to -6 diopters or axial length of more than or equal to 26 millimeters. The incidence of high myopia is increasing rapidly, especially in the Asian countries. And correspondingly, as the most common complication of high myopia, the incidence of highly myopic cataract is increasing year by year. And it accounts for 30% of the total cataract surgeries in the tertiary hospitals. The patients with axial myopia, these are at risk for suboptimal refractive outcomes following the cataract surgery. Although the patients with normal axial length, they achieve the refractive outcome within the predicted 0.5 diopters in 67 to 72% of the cases, whereas only 54% of those with axial myopia, they attain the target refraction when no optimization method is used. The pre-op axial length determination, the post-op anterior chamber depth, and the effective lens position, these are the important causes for the inaccurate IOL power calculation in high myopes. So in our study, a total of 26 eyes of 13 patients were evaluated in the studies, and both the eyes had an axial length of greater than 26 millimeter, and the patient's ocular dominance was checked. The inclusion criteria being biometric measurements done only by IOL Master 700, and the cataract surgery was performed by phacoemulsification with in-the-bag IOL implantation, and both the eye cataract surgery was planned. The patients with previous intraocular surgeries or intraoperative or postoperative complications were excluded, and the patients with pre-existing ocular diseases such as keratoconus, corneal scarring, endothelial dystrophies, and retinal detachment were excluded. And the patients who underwent any combined surgical procedures were also excluded. And the patients with follow-up of less than 1 month. So our baseline characteristics of the study population was, the age group was between 25 to 80 years. The axial length of all these patients was about 26 millimeters. It was between 26.24 to 35.02. And the IOL power target refraction emmetropia was minus 9.5 to 13.5. And the IOL power which was selected by the surgeons was between minus 7 to plus 13 diopters. And the IOL power implanted was the same. So without any financial interest, in 80% of the cases, the Acris of IQ and Acris of Expand was used. In 16% of the cases, Rayner Ray-1 was used, and 4% cases had Sensar 3Ps. And IOL power optimization was done depending upon the IOL power which is obtained. So if the IOL power is between 0 to minus 10 diopter, the target refraction was kept as minus 2 diopters. If the IOL power is between the range of plus 1 to plus 10, in these cases the target refraction was kept as minus 1.5 diopters, and anywhere above 11 it was kept as minus 1 diopter. So this is the IOL Master 700 chart. Okay, the axial length of this patient is 35.02, and the Acris of Expanded is showing minus 5.5. Okay, so our optometrist had, he had put minus 4, but depending upon the other eye status and our nomogram which was placed, we had decided to go ahead with minus 3 diopters. So in our study, we found that 92% of the cases had achieved the uncorrected visual acuity of 6/9. Okay, and 4% was within the range of 6/12, and other 4 was 6/18. So to conclude, monovision was achieved in these high myopic patients, and thus these patients had less spectacle dependence. Post-op predicted refractive results were obtained in 92% of the cases. Fine-tuning glasses were advised to the patients, and monovision is a good option for spectacle independence because trifocal and multifocal IOL powers are not available in such high myopes. These are the references. Thank you, sir.
Thank you. I think that was quite a good study. And your topic was optimizing of the IOL power. And so you're happy with the optimizing nomograms that you're using?
Yes, sir. So our professor, Dr. Sri Ganesh, sir, he is talking with Professor Graham Barrett, and they are coming up with a nomogram, sir, regarding optimizing the IOL power.
Very much needed. Okay, so any observation about posterior staphyloma in these patients?
Yes, sir, they were there, sir.
Were there any surprises after?
No, sir. In 92% of the cases, the predicted outcome which was kept, it was achieved, sir, which was within the diopter to have that spectacle independence in these cases.
Sir. Okay, thank you.
Thank you, sir. Thank you, ma'am.
I invite Dr. Manpreet Kaur for her presentation titled Long-Term Assessment of PC-IOL Optic Adherence and ND-YAG Capsulotomy Rate of Surface Modified.
Timer.
Thank you, sir. A very good evening to all of you. So I'll be speaking on long-term assessment of posterior capsule IOL optic adherence and its impact on ND-YAG capsulotomy rates after implantation of a surface modified intraocular lens. There are no financial disclosures. So surface modifications include surface coating, covalent grafting, plasma treatment, photochemical immobilization. The purpose is to enhance the biocompatibility of these IOLs and lead to a significant decrease in the incidence of posterior capsular opacification. So Vivinex is an aspheric hydrophobic acrylic IOL with posterior surface ozone modification, ozone treatment. Mechanism is there's an increased adhesion of fibronectin and lens epithelial cells to the posterior IOL surface, which promotes IOL adhesion to the posterior lens capsule and theoretically prevents PCO. So the purpose of the study was to assess the PC to IOL optic adherence in surface modified IOLs and its impact on ND-YAG capsulotomy rate and visual quality. Thus, it was a prospective interventional study performed at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. 93 eyes with immature senile cataract grade 2 to 4 were implanted with the hydrophobic acrylic IOL with posterior surface ozone modification. Cases with ocular or systemic comorbidities were excluded. Primary outcome was the PC adhesion to IOL optic as assessed using anterior segment optical coherence tomography and the ND-YAG capsulotomy rate. Secondary outcome was visual quality as assessed using ray tracing aberrometry. The follow-up was performed on postoperative day 1, 1 and 2 years. The mean age of the patients were 59.46 plus minus 9.14 years, 37 were bilaterally implanted, 19 were unilateral cases. No case had an intraoperative posterior capsular rent or vitreous loss. At 2 years, 94.6% had corrected distance visual acuity of 20/20 or better. 100% had corrected distance visual acuity of 20/32 or better. So this is just an example of one case on the left-hand side with a complete PC optic adhesion at 2 years in a case with initial smooth posterior capsule configuration. On postoperative day 1, 497 microns of fluid was present with decreased to 80 microns at 1 year. And at 2 years, there's a complete PC IOL adhesion as assessed using ASOCT. In the second case on the right-hand side, you can see a persistent PC optic inadhesion at 2 years. Initial wavy configuration of the capsule with 255 microns fluid, which reduced to 137 microns at 1 year. Even at 2 years, 96 microns of fluid was there in the visual axis. So on postoperative day 1, only 2.9% of our cases had a complete PC to IOL optic adhesion. At 1 year, this figure increased to 67.6%. At 2 years, it increased to 73.5%. Of note, more than a quarter of cases still had persistent PC optic inadhesion. This contrasts with a study by Zhu et al., who evaluated PC optic adhesion in visual axis after phacoemulsion emulsification using stream plug imaging. They observed 41.5% cases had persistent inadhesion at 1 day and only 7.1% had inadhesion at 2 months. So in their case series, 93% were completely adhered by 2 months. However, they used stream plug imaging, which is much less sensitive than ASOCT, and these difference of microns may not be picked up, and it may have underestimated PC optic inadhesion. So why is it important? The residual PC optic distance, which ranged from 0 to 182 micron, positively correlates with the total higher order aberration with the Pearson correlation coefficient of 0.4 and a p-value of 0.03. Strel ratio and modulation transfer function, root mean square total aberrations were significantly better with complete PC optic adhesion. Posterior capsular opacification developed in 7.5% cases at 2 years. Peripheral PCO is seen in this case with a clear visual axis in a case at 2 years, and no PCO was seen in 92.5% cases. So at 2 years, in these 7.5% cases, 85.7% of these had persistent PC optic non-adhesion. Nd:YAG capsulotomy was needed in 3.2%. Of note, all the cases that required a laser capsulotomy had persistent PC optic non-adhesion. So visually significant PCO developed in the cases only with PC optic non-adhesion. So just to conclude, surface modified IOLs are expected to have higher rates of PC optic adhesion with less PCO. Nearly 2/3 of our cases at 1 year and nearly 3/4 of our cases at 2 years had complete PC optic adhesion. Complete PC optic adhesion is associated with a superior visual quality, less posterior capsular opacification, and no need for Nd:YAG laser capsulotomy. This was the first study to characterize PC optic adhesion using high definition ASOCT in a surface modified hydrophobic acrylic IOL and correlated with visual quality. Thank you for a patient hearing.
Thank you, Dr. Manpreet. I think that was a very good and useful, timely study. And could you just tell us, is there any reversal, use PC optic adhesion you find maybe in whatever 1 year study and then it goes back some? Was there any case?
In one case.
In one case.
In one case in which the IOL was not completely covered with the rhexis margin. So eventually the cells, we assume, proliferated through that, and there was a mild decentration relative to every other IOL which was perfectly well centered, and the PC optic increased, distance increased, and it developed a PCO as well.
Okay, another relatively important question. You said 7.5% YAG. How many percent?
YAG in 3%.
PCO
and 7.5%.
7.5. And but were there any case which had full adhesion?
So 85% of these had persistent PC optic non-adhesion.
Non-adhesion.
Of the PCO, not the Nd:YAG rates.
Okay. Was there any PCO?
They were PCO peripheral, but YAG was not required. In the cases requiring YAG, all of them had inadhesion.
Thank you. That will help us clinically to decide the lens. Any other questions?
My question to you is, when you did this study, whether the corneal diameter or in a bag diameter was considered or no? Because that also plays a major role in deciding for the size of an IOL and the bag size.
Was not considered, sir. We did not consider. Yes.
So these are all normal cases. We excluded all the abnormal
extremes.
And treatment of those IOLs, surface modification was done by that.
It's a type of IOL that is ozone surface modified UV cross-linking. Yes, sir.
Thanks.
Okay.
Thank you.
That's all. Thank you.
So I call upon the next speaker, and this presentation would be by Dr. Sanket Bhatnagar. Title of the study is Comparing Accuracy of Toric IOL Power Calculations with Anti-AS Swept Source OCT and Standard Devices.
Good evening everyone, I'm Dr. Sanket and I'll be presenting my study titled Comparing Accuracy of Toric IOL Power Calculations with Anterior Segments SS OCT with Standard Devices. I have no financial disclosures to make. So, with increase in incidence of astigmatism in our senile cataracts and also demand for better post-operative results, correcting astigmatism in cataract surgery has always been a conundrum for most of the phaco surgeons. So, when we have to do a precise power calculation, what we really need is a precise keratometry and biometry, which paves the way forward for our reducing SIA. So we have a big arsenal of scans in our diagnostics, of which biometry, topography, and maybe abrometry plays a pivotal role. But when we send our patients, most of which who are in the senile age group, through a battery of these scans, it can be very time consuming, ergonomically a little difficult, and also puts a financial strain on most of the practitioners. So this begs us to ask us, and also COVID-19 as an epidemic has pushed us or put light on this fact that we need to go for lesser contact points and go for shorter imaging protocols. So this begs us to ask us that, is there a single imaging platform which is reliable enough to give us maybe comparable, if not a precise keratometry and biometry than our standard devices for toric calculations? So this is where Antirion by Heidelberg comes into picture. It is a multimodal imaging platform for anterior segment optimization, which uses highest resolution SWEPSO OCT with 1300 nanometer wavelength, which gives us a longer wavelength or a scan depth and low scatter. It combines topography and tomography with biometry, and also has a eye tracking technology, which gives us faster acquisition time. And there is a provision of using Oculix, which is a ray tracing software, which gives us more accurate results. So a single machine gives us biometry, topography, is used as an anterior segment OCT and also as an inbuilt toric IL planner. But can it replace our standard topography and biometry devices? So we conducted our study with the purpose being to compare reliability and agreement of parameters which were measured between Antirion, ILMaster 700 and Oculizer. We also compared the residual corneal astigmatism post-operatively, which was achieved by Antirion toric planning and by the toric planning done by conventional devices, and assessed the mean prediction error post-operatively. So in our study, which was a prospective interventional study, 42 eyes of 32 patients between 50 to 75 years of age with acquired senile cataract and astigmatism of more than 1 diopter with normal corneas and no other ocular pathology underwent clear corneal phacoemulsification by a single surgeon, where a temporal 2.2 millimeter incision was made and a toric monofocal aspheric IL was implanted. So pre-operatively and post-operatively at day 30th, all the patients underwent visual acuity, manifest refraction, and detailed slit lamp examination. Both ILMaster and Antirion were used to measure mean keratometry, astigmatism, pachymetry, axial length, and biometry. We gauged the mean keratometry, astigmatism, and pachymetry through Oculizer. Coming to toric planning, biometry and topography from Oculizer and ILMaster were used, and Alcon online toric calculator was used to calculate the IL power and the cylinder which was residual. Parallelly, Antirion was used to do the topography and biometry, and the inbuilt toric calculator was used with the same A constant and formula that was used. Now, through the conventional devices, whatever power was calculated, Acrisoft IQ toric lens was implanted based on that. Now, coming to the results, in our sample size of 42 eyes of 32 patients, mean IOL implanted was plus 23.52 diopters, and there was a statistically significant change in visual acuity, residual corneal astigmatism, and mean spherical equivalent pre and post operatively. Now, coming to or surveying the intraclass or surveying the repeatability, intraclass coefficient correlation was used, and Antirion showed moderate to good repeatability for most of the parameters with excellent repeatability for axial length. Most of the parameters that were measured, which were mean preoperative astigmatic power, keratometric values, axial length, and pachymetry, had no statistically significant difference in variability. Also, the Bland-Ullmann plot showed good to excellent agreement between parameters measured by Antirion and ILMaster, particularly for axial length. So, to gauge the accuracy of toric planning in the conventional devices, and Antirion mean prediction error analysis was done, which was measured as a difference between the actual residual astigmatism and what was targeted. And though there was no statistically significant difference, Antirion showed a lesser mean prediction error. So what we knew was that predictive accuracy of toric IL power calculation depends on precise biometry and keratometry, and there are multiple biometers and keratometers at hand, and a composite workup on these is required for toric power calculation. But in this study, what we have seen is Antirion gives us moderate to good repeatability for most of the pivotal parameters that we have, and has good agreement with IL master for biometry and also topography. Also, it has lower prediction error in toric calculation compared to toric calculation with conventional devices. So to conclude, based on this study only, Heidelberg Antirion with its longer wavelength and larger penetration depth can be used as a single platform for imaging and biometry and keratometry for toric power calculation. But this study was not without its limitations. It had a smaller sample size and the follow-up period was only 1 month post-operative. Also, the toricity of IL implanted were not considered, which can be a confounding factor. And vector analysis is still, we are looking for more sample size, so it's in the pipeline. And maybe in the future, we'll be presenting the vector analysis where we can see the change in diopter and access pre and post-operatively. Thank you.
Sir.
Yes.
So your comparison was with IL Master 700.
Yes.
Right. Now COVID is over.
Yes.
Whether you can still calculate within a, because everyone doesn't have an one machine. You know, I mean, if you have an say 2 machines or 3 machines, you have an topo, you have an say swept source biometer, and then still you feel that the results.
So we can still reduce the burden of machines in a diagnostic cancer. If Antirion is reliable enough, why only IL master, which can be, we are still not very sure that it is giving as good or reliable parameters at pentacam. Lot of people are going with pentacam and oculizer still for topography and astigmatic power, sir. Plus it has a toric planner inbuilt with Oculix, sir. So maybe.
Okay. Now the second question comes.
Yes, sir.
Have you any comparison of an Antirion with an Argus?
Which, sir?
With Argus.
No, sir. We don't.
Because that is proved to be having a better keratometry than.
So we are collecting data because it's a prospective study. We have to maybe have a longer follow up also, sir, with these machines also.
Thank you so much.
Thank you, sir. Thank you.
Yeah. So now I call upon Dr. Saurabh Patwardhan. He will be presenting a newer technique, sideways sculpting, in case of posterior polar cataract with nuclear sclerosis. Dr. Saurabh.
Thank you, sir. Good evening, everyone. And my paper is on innovative method of sideways sculpting for nucleotomy in cases of harder posterior polar cataracts. So we all know that posterior polar cataract or PPC have always been a challenge for cataract surgeons because there is always inherently higher propensity for posterior capsule rupture, and it may be possible adherence of the PPC to the posterior capsule. That's why there is a higher risk. Now there are various conventional techniques or tips which are given, such as avoid large anterior CCC or take a oval CCC so that ease of optic capture is there. Avoid deepening or shallowing of anterior chamber during procedure. Avoid hydrodissection but perform hydrodelineation. There should be no nucleus or lens rotation during surgery. Low vacuum or low flow parameters, and avoid capsular polishing. In this study, we used Daljit Singh classification of posterior polar cataract, where we are more focused on the type 4 of the classification, where there were different signs of PPC were present, but along with that, there was nuclear sclerotic cataract as well. So the purpose of the study was to introduce an innovative method of sideways sculpting for nucleus management in cases of harder posterior polar cataract. We included posterior polar cataracts with nuclear sclerosis of grade 2 and above, and excluded anything with nuclear sclerosis less than grade 2. These are retrospective analysis of last 4 years. 17 eyes of 17 patients with posterior polar cataract were included in the study. Single surgeon performed all the surgeries, and I will show the exact method using the video, so it is better than giving description. Let's hope the video plays. Okay. So in this technique, basically what we are doing is creating the same divide and conquer method, but we are doing this without any nucleus rotation. So for softer grade of cataract like this, we can easily do layer by layer phacoemulsification. So we can just aspirate out the nucleus without need of any nucleus rotation. But as we have to do the nucleus chopping or nucleus division in case of harder grade of cataracts with PPC, then that poses a challenge. So in this video, I will just show how this sideways sculpting is done. In this videos, I am using Ozil phaco. So first, the central deep trench is done, just like the regular trench divide technique. And after doing the first trench, rather than dividing the nucleus, we do this sideways sculpting. So the tip is moved sideways rather than rotating the nucleus. So in the same, when the lens is sitting the same, we are doing perpendicular, basically sculpts or grooves without rotation of the nucleus. And if once the adequate depth is achieved, we have 4 quadrants which are ready to be taken out from the bag without requirement of the rotation of the nucleus. So we'll see this in this video again. So the first deep groove, first trench is done, and then you can see the video is little choppy. Okay, so the sideways movement of the phaco tip is used. So once these 4 quadrants are there, just see that I am not dividing the central part till the end. And now once these 4 petals are there, I can just take these out petals one by one, and I am just pulling these nucleus pieces out of the bag rather than rotating the nucleus. So this was a grade 2 cataract, but this was a denser cataract using the similar technique. Again, see, the first trench is done, only partial division is done, and then sideways trenching. The video is becoming choppy. Anyway, so again the same thing is done with even the harder grade of cataract. You can see I can easily remove these pieces without any nucleus rotation, because that is the common step when we realize that the posterior capsular has caused dehiscence and nucleus may drop. So in this technique, we are not doing any nucleus rotation, and still we are able to remove the harder or nuclear grade cataracts. So the cases were uneventful without any complication. Only in one case there was a small opening of the posterior capsule, but the IOL could be implanted in the bag. So for harder grades of cataract, because the nucleus must be divided as compared to softer grade of cataracts, where the nucleus can be aspirated without dividing, this technique really helps in nucleus division without any nucleus rotation. So the goal of performing phacoemulsion in eyes with PPC is to prevent, delay or minimize the complication. This technique can be used with torsional as well as longitudinal phaco, but it is easiest with 45-degree tip and Ozil phaco. To conclude, this innovative surgical technique provides nucleus division and emulsification without distorting or exerting traction on the weak posterior capsule. This is a useful technique for PPC with nucleus crosses of grade of 2 or more. Thank you, sir.
I think the study is very innovative, no doubt about it. But we need to, I think, carry this study for many more patients.
Yes.
And is there any difference in the learning curve, or it's like any other phaco surgery?
It will be difficult for me to comment because I am already an experienced surgeon who is performing.
But supposing a phaco surgeon wants to learn this technique,
it's not difficult because of course I would, as I said, for torsional phaco it might be easier because with torsional the sculpting is easier, so you can manipulate it very easily. With longitudinal also one can do, like because the similar questions were asked to me, so I tried it with longitudinal as well as with straight tips. It's a bit difficult because when you have a straight tip, you kind of distort the bag a bit. So best is Ozil with 45-degree Kelman tip, but you can use any other tip as well. Yes.
Thank you.
Sometimes there is a pre-existing dehiscence in these capsules. Did you find any of these cases?
Yeah, so in one case we found that the posterior capsule was open after I removed everything, but luckily it didn't extend. Yeah.
Will it not be difficult because you've got smaller pieces and you've divided into 4 at that time?
So in this technique, what we are doing, when we are dividing, we are avoiding the central division. So it is like petals. We are taking those petals out. So the last piece is still left. Last time in the central part is still left.
How do you manage the last piece?
No, it's a epinucleus basically. The last central part is a epinucleus. So we use the standard technique.
Visco?
Yeah, either visco dissection, or if it is already separate, then with just aspiration. Yes.
Okay.
Thank you.
Thank you.